All right, ready for another deep dive? This one's for all you Canadian med students out there gearing up for the MCCQE.
You got it. We're here to make this whole exam review thing a little less intimidating, right?
Exactly. I'm Harvey, by the way.
And I'm Donna.
And we both actually review for the MCCQE ourselves, so we thought, why not share some of that knowledge, break down those big concepts, and make it, a little more digestible.
Yeah, we're drawing on some solid sources too, like stat pearls, to give you a taste of what the exam is really looking for.
But got to put that disclaimer out there. This is not medical advice. Always, always consult with a qualified healthcare professional for the real deal.
Definitely. We're your study buddies, not your doctors. So that said, let's dive in, shall we? Today, it's all about asthma.
Asthma, huh? Seems pretty straightforward, right? Wheezing, shortness of breath, inhaler, done.
Ah, if only it were that simple. That's what the MCCQE loves to do. They go deep. Stat Pearls, for example, really emphasizes how it's not just a simple wheeze. We're talking a whole spectrum of severity here, from the occasional cough to, life-threatening airway closure.
Okay, so right off the bat, we're seeing this isn't your basic asthma 101. Stat Pearls even mentions that for some people, the only symptom might be a cough, especially at night. No classic wheezing at all.
Exactly. And that's where things get tricky. Imagine a patient comes in with just a cough. You're not automatically jumping to asthma, are you? So understanding the full spectrum, that's key for the MCCQE.
For sure. Got to think outside the box.
Yeah.
Right? Stat Pearls also throws this out there. 40% of children wheeze, but only 1% of adults actually have asthma. What's the deal with that? Seems like a bit of a disconnect.
It really highlights how asthma isn't just one thing. It's this mix of genes and environment. Early wheezing doesn't automatically equal lifelong asthma. Things like exposure to smoke, pollution, those can play a huge role.
So, early wheezing may be a red flag, but not a guarantee. Got it. Let's say we do suspect asthma, though. Stat Pearl says spirometry is the gold standard, but even that's not always a slam dunk.
Right. Sometimes the results can be totally normal, even with asthma, especially if someone's between attacks or has what they call cough variant asthma.
Cough variant asthma. That sounds like a classic MCCQE question waiting to happen. Break that down for us.
It's basically asthma, where the main symptom is, you guessed it, a cough. But they might not have the typical wheezing or shortness of breath. Easy to miss, especially if you're only looking for the classic signs.
So spirometry, not perfect. What other tools are in our diagnostic toolkit, especially for those less obvious cases?
Stat Pearls talks about something called bronchoprovocation testing. Sounds kind of crazy, but you're intentionally triggering bronchoconstriction to see how the airways react. Helps diagnose those tricky cases where spirometry is inconclusive.
Intentionally making things worse to figure out what's wrong. Medicine is wild.
It is. And then there's FeNO, fractional exhaled nitric oxide. It measures inflammation in the airways. Higher levels usually mean eosinophilic inflammation, which is a big part of asthma.
Okay, so it's not just about how well the air is flowing, but what's causing the inflammation in the first place. Got it. We've got our diagnostic tools down. What about treatment? Stat Pearls really emphasizes this stepwise approach, tailoring it to how severe the asthma is.
Exactly. It's not one size fits all. First, you've got your quick relief meds, the rescue inhalers, the beta agonists like albuterol. Those are the stars of the show.
Albuterol, the good old blue inhaler.
Yeah.
But I'm guessing there's more to it than just take 2 puffs and call it a day, right?
Oh, yeah, for sure. Stat Pearls points out this crucial thing. How you deliver the medication actually impacts the dosage. Inhaler versus nebulizer, it changes how much medicine actually gets to the lungs.
So even something as basic as how you give the medicine can make a difference. Classic MCCQE detail.
Absolutely. They want to see that you're thinking about the practical stuff, not just memorizing names. And for folks with persistent asthma, that's when you bring in the controller meds, like inhaled corticosteroids.
Inhaled corticosteroids, the bread and butter of long-term asthma management. But like all meds, there are potential side effects, right? What should we be watching out for?
Stat Pearls highlight the risk of pneumonia, especially if there are other risk factors. It's not super common, but definitely is something to keep on your radar.
Okay, inhaled corticosteroids, got it. But what about those patients with severe asthma that just doesn't respond to the usual treatments? What do we do then?
Ah, that's where things get really exciting. Biologics. These are cutting-edge therapies that target those specific inflammatory pathways in a way that traditional treatments can't.
Biologics? Fancy. Sounds like something straight out of a research journal. So how do they actually work?
Well, there are different types, but some, like mepolizumab and reslizumab, they go after a specific white blood cell, eosinophils, which play a big role in the inflammation.
So they're taking out the inflammatory bad guys with, like, Laser precision.
Exactly. And because they're so targeted, they can be super effective for those tough cases, the severe, difficult to treat asthma.
Fascinating stuff. But I have a feeling we're just scratching the surface here. We've got diagnostic tools, all these different levels of treatment, even these high-tech biologics. It's a lot.
You're telling me, but we're just getting started. There's so much more to uncover when it comes to asthma and what the MCCQE expects you to know. So before we went on that tangent about biologics, remember we were talking about those personalized action plans, super important for patients to really take control of their asthma, right? Stat Pearls really stresses that.
Yeah, it's not just a nice little bonus. It sounds like these plans are crucial. What do they actually look like in practice, though?
Well, they're usually based on either how bad the symptoms are or peak flow readings, and they're divided into zones, kind of like a traffic light. Green, yellow, red.
Okay, I like that. Easy to visualize.
Right. So green means everything's A, okay, symptoms are controlled, peak flows are good, 80% or higher than their personal best, and they just stick with their regular meds.
Green for go? Makes sense.
Exactly. Then there's yellow, caution time. Peak flows have dipped, maybe between 50 and 79%. They might be noticing symptoms, stuff that interferes with their day-to-day.
So yellow's like a heads up, time to pay attention, maybe take some extra steps.
Right, and their action plan will spell out those steps, like upping their rescue inhaler use or adding another medication. And then, of course, there's red, stop, drop, and get help, basically.
Very dangerous.
You got it. Peak flows are below 50%. They're really struggling to breathe. Life's on hold. This is when they need to call their doctor or head to the ER.
Got it. Green, good. Yellow, caution. Red, emergency. Easy peasy.
And having this plan laid out can make such a difference for patients. It puts them in the driver's seat, helps them avoid those last-minute scrambles when things get bad.
Yeah, I can see why this would be a big deal for the MCCQE. They love to test if you can actually apply the knowledge, and this is a perfect example.
Absolutely. It's not about spitting back facts. It's about knowing how to use them to take care of real people. Speaking of which, let's dig a little deeper into those treatment options. We touched on them before, but Stat Pearls has this whole stepwise approach, worth breaking down, I think.
Okay, let's walk through it step by step. Starting with those quick relief meds, what's the go-to for an asthma attack? The classic.
Albuterol, our trusty beta agonist, it's the first line of defense, works fast to open up those airways.
Albuterol, every med student's best friend during those rotations. But Staples mentioned the delivery method matters, right?
Huge difference. Metered dose inhaler with a spacer. That's usually preferred over a nebulizer, especially for those mild to moderate attacks. You get more bang for your buck, more medicine where it needs to be.
Inhaler plus spacer, got it. But there are other quick relief meds out there, right? Like anticholinergics. How do they fit in?
Ipratropium bromide, that's a good example. It's often used with albuterol, especially for moderate to severe attacks. They work together, kind of like a 1-2 punch, relaxing those airway muscles from different angles.
Synergy. Teamwork, even in pharmacology.
Exactly. Okay, moving on to the long-term control meds, the ones that prevent the attacks in the first place. What's the big one, the foundation?
Inhaled corticosteroids, no question. They're the workhorse, keeping that inflammation under control.
Exactly. But gotta remember, they come with potential side effects. Thrush, hoarseness, that slight increased risk of pneumonia. Important to teach patients the right inhaler technique, minimize those risks.
Rinse and spit, right. Got it. But what if the inhaled corticosteroids aren't cutting it on their own? What's next?
Well, you can add a long-acting beta agonist, a LABOBA, to the mix. They provide longer-lasting bronchodilation compared to albuterol.
Like albuterol's big brother, but with more stamina.
Something like that. Lobies, like salmeterol and formoterol, great for more frequent symptoms. And there's more and more evidence that combining a LABA and an inhaled corticosteroid in one inhaler, that's even more effective.
Two birds, one stone. Efficient. So we've got inhaled corticosteroids, labias, combo inhalers. Anything else in the long-term management toolkit?
Leukotriene modifiers, montelukast is a common one. They block these inflammatory chemicals, play a role in asthma, not as potent as inhaled corticosteroids, but can be a good add-on.
Leukotriene modifiers attacking inflammation from a different angle.
Oh.
Cool. But what about those patients, severe asthma, not responding well to any of these traditional treatments? That's where the biologics come in, right?
Exactly. Those are like the special forces, highly targeted, really effective for those tough cases.
So break it down for me, these biologics. What are the big ones? How they work their magic?
One of the key targets is interleukin-5, or IL-5. It's a cytokine involved in making those eosinophils, the inflammatory white blood cells. Block IL-5, fewer eosinophils, less inflammation.
Sounds pretty direct.
It is. There are a few monoclonal antibodies that do just that. Mepolizumab, rslizumab, they're given by injection every few weeks. Really impressive results, less exacerbations, better lung function, especially for those with severe eosinophilic asthma.
Eosinophilic asthma, that's where eosinophils are driving the inflammation, right?
Exactly. Not everyone with asthma has those elevated eosinophils, so these biologics are specifically for that group.
Okay, so IL-5 blockers for eosinophilic asthma. What other biologics are on the scene?
Another target is the IL-4 receptor. Dupilumab, it blocks this receptor, and it's actually approved for both asthma and atopic dermatitis, another allergic inflammatory condition.
Two for one deal, huh? Tackling two inflammatory conditions at once.
That's right. It's been shown to reduce exacerbations, improve lung function, moderate to severe asthma, and this one doesn't matter if their eosinophil levels are high or not.
Interesting. So IL-5 blockers, very specific for eosinophilic asthma, but dupilumab has a broader reach.
Exactly. And then there's tezepelumab. It targets something called TSLP, thymic-stromal lymphopoietin, a cytokine involved very early on in the whole inflammatory cascade.
So instead of tackling the players of the game, this one's going after the coach, stopping the inflammation before it even starts.
I like that analogy. And because it's targeting that early part of the pathway, it could potentially help a wider range of patients.
Okay, so we've got this whole arsenal of biologics, each with its own mechanism, target. Amazing how far asthma treatment has come. But with all these options, how do you choose the right one for a specific patient?
That's where personalized medicine comes in. Asthma, it's not a one-size-fits-all thing. You got to consider the patient's age, how bad their symptoms are, what triggers their asthma, how they responded to past treatments, even their
Take
preferences.
solving a puzzle, all these different pieces to consider.
Exactly. And shared decision-making, super important. Involve the patient, talk about the risks and benefits, come up with a plan that works for them.
I like that. It's not just about throwing meds at the problem. It's about working together with the patient.
Absolutely. And that's something the MCCQE really cares about, that patient-centered approach.
All right, we've covered the whole stepwise approach, from those quick relief meds to those fancy biologics. But we can't forget about acute exacerbations, those moments when things flare up, get potentially dangerous. What do we as future doctors absolutely need to know about managing those situations?
First thing, recognizing when it's serious, when it needs immediate attention. Remember those red flags? Struggling to speak, low peak flows, oxygen levels dropping.
Red flags, check. So we see those, what's the game plan? What do we do right away?
First, make sure they're getting enough oxygen, nasal cannula, or a mask, depends how bad it is. Then, those quick relief meds, gotta get those in fast, usually albuterol, inhaler with a spacer or nebulizer.
Albuterol, always saving the day.
Pretty much. Depending on how severe it is, you might add euprotopium bromide, get that extra boost. And in really bad cases, you might even need systemic corticosteroids, oral or IV.
Okay, oxygen, quick relief meds, maybe systemic corticosteroids. What about magnesium sulfate? We talked about that earlier, potential lifesaver.
You're right. Magnesium sulfate can be a game changer for those who aren't responding well at first. It relaxes the airway muscles, can help avoid intubation.
Like a secret weapon?
You could say that, but it's not something you use all the time. It's for those really tough cases when they're at risk of respiratory failure.
Got it. Magnesium sulfate for when things get real. But worst case scenario, breathing is really compromised, nothing else is working. What then?
That's when you might have to consider intubation and mechanical ventilation. It's a big decision, obviously, but it can be life-saving.
Intubation, the big guns, definitely serious stuff. But beyond those immediate steps, what else matters when someone's having an acute exacerbation?
You got to figure out what triggered it in the first place. Was it an infection, an allergen, smoke, irritants? Identifying that trigger, that's key for preventing future episodes.
Like detective work, finding those clues.
Exactly. And then you need to educate the patient, how to prevent those exacerbations, avoiding triggers, using their meds correctly, having a plan when symptoms flare up.
So it's not just about treating the attack, it's about giving them the tools to manage their asthma in the long run.
Absolutely. That's what comprehensive care is all about. And it's something the MCCQE really values.
Okay, we've covered a lot of ground here. The whole stepwise approach, from quick relief meds to those cutting-edge biologics, and then managing those acute situations. Anything that really stands out to you, someone prepping for the MCCQE should really take to heart.
I think it really gets me is just how complex asthma is. It's not just a cough or a wheeze, it's this multifaceted condition, so many ways it can present, different levels of severity. And the exam, it's going to test your understanding of all that, how to apply what you know to real-life scenarios, from those tricky diagnoses to coming up with personalized treatments to handling emergencies.
Totally agree.
Yeah.
And for me, the big takeaway is the power of patient education, working together to make decisions. Asthma, it requires people to be actively involved in their own care, and the MCCQE, they get that. They value those patient-centered skills.
Couldn't have said it better myself.
Yeah.
And on that note, why don't we move on to the final part of our deep dive? We'll wrap things up with some final thoughts, some things to chew on as you keep prepping for the MCCQE. All right, so we've covered a ton about asthma, how to diagnose it, all those different treatment options, but there's one more thing Stat Pearls really emphasizes.
Oh, how's that?
It's about those patients who are at a really high risk for those severe attacks, the ones that can be life-threatening. Being able to spot those red flags early on, that's crucial.
Okay, so we're talking about more than just managing everyday symptoms. We're talking about anticipating those worst-case scenarios, those really serious situations. What are the signs? What should we be looking out for?
Well, Stat Pearls lists a few specific things, like if someone's already been intubated for asthma in the past, that's a big one. Or if they've been hospitalized for asthma 2 or more times in the past year, that's another red flag. And then there are factors that you might not think about right away, like mental health struggles or a tough social situation. Those can actually increase the risk too.
Wow, so it's not just about their physical health, their lungs, it's
Yeah.
about their whole life situation, their well-being overall. That's really interesting.
Exactly. And the MCCQE, they want to see that you're considering the whole person, not just their asthma. There are other things to watch out for, too, like if someone needs more than 2 canisters of albuterol a month, or if they're still needing systemic corticosteroids even though they're on those daily controller meds, those are signs that things might be getting worse.
So if their asthma is acting up, even though they're doing everything they're supposed to, that's a big warning sign.
Absolutely. And the point is, if you can spot these high-risk patients early on, you can be more proactive, adjust their treatment, and hopefully prevent those really bad outcomes down the line.
It's not just about managing asthma, it's about preventing those really serious situations, potentially saving lives.
Exactly. And that goes back to what we were talking about earlier, understanding why you're doing each step of the treatment. The MCCQE, they want to see that you can think critically, make those smart decisions, even when things get complicated.
Right. You can't just memorize the guidelines. You have to know why they exist in the first place. But why is that so important for the exam?
Because they're going to throw you curveballs. Those scenarios where the answer isn't super obvious, those situations where you have to really think it through. They want to see that you can apply those core principles even when it's tough.
So it's like having a mental map, not just following directions. I get it. But to be honest, all this talk about severe asthma and those high-stakes decisions, it's a little intimidating.
Yeah. I hear you. It's a lot to take in. But remember, you don't have to know everything off the top of your head. Focus on building that strong foundation, those core principles of how to manage asthma, understand the inflammation process, the different meds, how important personalized treatment is.
Get the basics down, then you can build from there. Makes sense.
Exactly. And don't be afraid to ask questions. Find mentors, talk to your classmates, learning from each other. That's huge.
Okay, that actually makes me feel a bit better. We've talked about so much today, diagnosis, treatment, those risk factors, what to do in emergencies. It's been a pretty intense deep dive. Is there one big idea, one thing you hope our listeners will take away from all of this?
For me, it's this. Asthma can be tough, but it's manageable. With the right knowledge, the right tools, and by really putting the patient at the center of it all, you can help people live their best lives, even with asthma. And who knows, maybe one of you listening will be the one to make the next big breakthrough in asthma care, right?
That's a great thought. It reminds me that we're not just studying for an exam, we're preparing to actually go out there and make a difference in people's lives.
Absolutely. So to everyone out there getting ready for the MCCQE, good luck. Keep learning, keep asking why, and never lose that passion for making a difference.
Couldn't have said better myself. And on that note, that wraps up another deep dive. Until next time, stay curious and keep those brains sharp.